Hey everyone, I'm Dr. Jeff Yu, a real board-certified ER doctor in both the USA and Canada. And today I'm going to be reviewing the Pitt Season 2, Episode 2. Let's get to it.
I'm going to check for internal hemorrhage with an ultrasound.
What is your gut telling you?
Or gut?
Yeah, it's this thing that AI will never have.
I don't.
So Dr. Robbie has a really good point here. We often train our residents and medical students to follow their gut or intuition or their sixth sense that they develop throughout their medical careers. And I agree that AI will never replace my job as an ER doctor because AI and robotics will never be able to successfully intubate a patient, drain an abscess, or run a complex resuscitation where all the information that's coming at you changes from minute to minute. And they would never be able to mimic the human interaction with all of the subtle cues that comes at you and be able to console a family whose child or family member had just died. I think it's one of the few jobs where it's going to be protected from AI.
58-year-old guy, triple scaphoid fracture, epistaxis, non-focal neuro, bitonized head trauma. But every time I check on him, his affect has drastically changed. My gut is telling me something's not right.
So this is a really interesting case. The patient has a potential scaphoid fracture, seems a little bit confused. His affect or his mood seems to change from time to time that she goes to visit the patient. So the few things that I would be thinking about in this scenario are one, psychiatric or mental illness, but the other thing, because the patient had an abrasion or a scrape to his chin, I would be really concerned that the patient has some kind of really bad traumatic brain injury or possibly even an intracranial bleed or a bleed inside the brain. If the patient was not cooperative and not willing to do further investigations like a CT scan, I think that there would be reasonable grounds in this scenario where you could enforce what we call the Healthcare Consent Act, whereby you can involuntarily do investigations and give the patient medications like sedatives to facilitate these investigations. The scenarios that we are able to use this rule is, if there's some kind of brain injury where they're not able to comprehend what's going on, alcohol intoxication, or psychiatric illness where, again, they aren't able to comprehend what's going on or understand the consequences for the decisions that they're making.
Boy, Alan Billings, pallet of roofing tiles fell 8 feet, hit his upper arm with an open dislocation. 2 rounds of fent, 1 then 0.5 per kilo, A&O with good vitals.
So A&O with good vitals means that the patient is alert and oriented, which points away from a bad brain injury.
And I'm Dr. Garcia from surgery.
And this is Dr. King.
Hi. Oh, it really hurts.
Give us a minute and we're going to take care of that, okay?
Any headache, chest or belly pain?
Oh, just the arm.
SAS 99, pulse 104, BP 116 over
What do you
78.
think, Dr. King?
It is an open dislocation.
Can you be more specific?
Luxatio erecta.
I think it's inferior, yeah?
Do you remember the name for that?
Sounds like a Harry Potter spell. Luxatio erecta.
That's it.
Check the neurocirc.
Sir, can you feel me touching you? Okay. Can you wiggle your fingers?
So what she's checking right now is the neurovascular status of the hand, primarily 3 different nerves that supply the hand: the median, ulnar, and radial distribution, as well as the vascular supply. So she was just feeling his pulse, which is his radial pulse over here. The other things that we would typically be doing is squeezing the nail beds to check to see how long it takes from it to go blanch to pink back up. We would want to see that the fingertips pink back up in less than 2 seconds. And then to check the nerve status, we would be checking to make sure that they're able to keep their fingers spread apart without us squeezing them back together, keep their thumb up without pushing it down, and keeping an O without allowing us to break their O, and check their sensation to light touch to their thumb, index finger, and their pinky.
Good radial pulse.
EFAST is negative.
Okay, what's the next thing for McKay?
So the EFAST is an ultrasound test that we do for trauma patients where we ultrasound 5 different parts. So we check the right upper quadrant, looking at the space between the liver and the kidney, the left upper quadrant, looking at the space between the spleen and the kidney, the pelvis directly where the bladder is to look for any free fluid or blood in the pelvis. And then we would be checking also the heart as well as both of the lungs. Sorry, that's 6 places, to make sure that there's no fluid around the heart, that would indicate bleeding in the sac around the heart, and to make sure that there's no signs of a collapsed lung.
NSF and gentamicin, sedate for traction and retraction.
You use a CT angiogram to rule out vascular injury.
So that's totally correct in that they're doing a CT angiogram, which is a CT scan where they inject dye. And the reason that they would do the CT scan with IV contrast is because where that humeral head, where that bone has protruded out, there's a lot of vessels that go through the armpit. There's a high risk of damage to all those vessels. So that's exactly what I would be doing in this scenario as well.
Sounds like a plan.
But with an open joint, he needs a washout in the OR with ortho.
Great.
Instead of wasting time down here, it should be easier to reduce under general anesthesia with fewer risks.
That's great.
So right now what they're deciding on is whether to take this patient to the operating room or whether they should reduce or put the shoulder back into place right there in the ER. Both has its risks and their benefits, but this is a very time-sensitive injury. And again, because the humeral head has such a high risk of pushing against all the nerves and the vasculature in the armpit, this is a very time-critical and time-sensitive procedure. And the risk of infection is much lower down because we could actually treat that with the ANSEF and gentamicin, which they already said that they were going to give. So typically, if we were going to take them to the operating room, it would take about 1 hour to have the operating rooms prepped and ready to go, and the patient actually wheeled up there and under sedation. Whereas if we were doing this in the emergency room, all we would do is we would insert an IV, we would do what we call procedural sedation, where we give the patient a combination of ketamine and propofol to get them completely flaccid, like all their muscles are completely disengaged. The patient is not feeling any pain, will not remember anything, and he's completely asleep. And then we would pull on the shoulder under traction to actually pop the shoulder back into joint. And that would solve the issue and the risk of damage to the vasculature and the nerves.
Come on, motherfucker! Humeral head is not reducing.
Should be done in the OR.
I am the OR.
Okay, we're gonna get this back.
So what they're performing is what we call traction counter traction. It's where one person stabilizes the body using a bed sheet around their chest or their kind of their neck over here, while the other person pulls traction on their arm. This is usually the most definitive way to get a joint back into place.
1, 2, 3.
Ooh.
Very cool.
So that clunk is actually very realistic. We see this all the time in the ER with regular anterior shoulder dislocations. I personally have never actually seen luxatio erecta before, but the clunk that they just showed on this TV show is exactly the way that the clunk of a shoulder reduction happens in real life.
Yeah.
You don't seem all right.
Well, my deposition is today.
Do you want to talk about it?
I'm not allowed to.
No, we don't have to talk about the position, but we can talk about how it is affecting you. Average emergency physician catches a med-mal case every 7 years. 9 times out of 10, the doctor wins. I've been sued 4 times myself. Dr. Al.
So Dr. Robbie seems like a really great attending, someone that I think I would personally get along really well with. I think the traits that he demonstrates is that he makes himself very vulnerable. He tries to normalize everything that the resident is experiencing. He also opens up the floor to discuss how it's impacting the resident's performance. And these are all really great traits of an attending that actually cares and is there for his residents.
I've never been named in a lawsuit.
I can say the same for the new attending.
How's the day going, Doc?
Yeah, pretty good. Looks like your albumin's infusing.
So one of the biggest problems with liver failure is that your liver stops producing albumin, which is one of the most abundant proteins in your bloodstream. Albumin helps to keep fluid inside the blood vessels, and if your albumin levels drop, then your fluid will start to leak in all the surrounding tissues in your cavities in what we call third spacing. So one of the ways that we treat tensitis, which is where all the fluid has leaked into the abdominal cavity, is first of all by draining out the fluid, but we would also infuse albumin back into the bloodstream so that your fluids don't leak straight back out.
Always make sure your entry point is safe by identifying the pocket of fluid.
That's not a pocket, that's a lake.
So this is actually very accurate. What he's doing is a bedside ultrasound. And all of the black on that ultrasound is fluid. All the white there is bowels or intestines. And this looks very realistic to what we would actually perform in real life.
Back, we pull up the skin before advancing into the peritoneal space.
So what they're doing here is live ultrasound guidance to insert the catheter to make sure that they're not puncturing any bowels or vessels. I think most of the time in real life, we're not using live ultrasound guidance. Typically what we'll do is we'll identify the pocket of fluid. And then once we've identified that it's safe and there's like, 1 or 2 inches of just fluid before you hit bowel, we would identify it by marking the skin and then puncture in and go from there.
I think they got this.
Oh, he's touching his stethoscope with his sterile gloves. That's a big no-no.
Typically something you use to glue shit. You break like coffee mugs and stuff. You know what I'm talking about. It's super glue.
Okay, yeah, got it.
So we are starting to see a lot more complications related to fake eyelashes and fake nails. One of the things that we see, apart from people gluing their eyelids shut like this, is something called a stye chalazion or hordeolum, because there's a lot of glands inside the eyelids, or what we call meibomian glands, which are oil glands, and glue, mascara, and eyeliner can actually block all those glands as well, which causes redness, swelling, and irritation. With fake nails, what we're seeing is these nails are glued so tightly to their nails and they're so long that people are getting their nails caught on different surfaces and ripping or lifting their nails off of the nail beds. So I think this is one of the big reasons why I typically tell my friends not to use fake eyelashes or fake nails.
Dr. Mohan, you got a minute?
Yeah.
Have you met Emma? First day, new grad RM?
Hi.
Nice to meet you.
Emma needs to learn cast removal.
So this elbow bump is something that we did a lot during COVID, but I don't really see anyone doing that anymore.
Okay, this cuts the cast, not the skin. This should relieve the itching.
So this is a real cast saw. This is something that we use every day in our practice. Essentially what it is a reciprocating saw. The saw moves back and forth and vibrates, so it wouldn't actually cut the skin, but it would cut a rigid object like the cast. I'm guessing they're not going to find something pretty under there. So I would typically be wearing a mask because the smell would be pretty intense from the cast coming off.
Oh, I see you brought some friends.
Oh my God, are those?
Maggots.
So maggots are one of the things in the ER that nobody likes dealing with. It's just always makes me really squeamish. I've seen a lot of maggots coming, like burrowing through different wounds, and it's just never a pretty sight.
So the appearance of the bacteria in your eye suggests that it's gonorrhea.
So if this was my resident or medical student, the biggest feedback that I would give to them is that they actually close the curtains and have this discussion in private, because obviously this is embarrassing, it's sensitive information, and you wouldn't want other patients or family members overhearing this conversation or being able to see the nun's reaction.
An app on my phone that can listen to our conversation and the details of my physical exam and write it all up in your medical record.
Wow.
So this is actually very realistic. This is happening right now in all of the ERs across North America.
Look on the bright side, we're gonna free up a bed and discharge a patient.
I mean, that's great for us, not so good for him.
He will get great care at Westbridge, don't you agree?
This is just a simple insurance transfer.
Yeah, okay.
So this is something that I can't really speak to. I work in the Canadian healthcare system where every hospital is public and everyone has universal healthcare. Whenever I see what happens in the USA with people not being able to receive care because they don't have healthcare insurance, or they have to go to a specific hospital to get care, and they end up in the wrong hospital and have to pay tens of thousands of dollars, sometimes hundreds of thousands of dollars because their insurance company won't pay for care at that hospital. I think it's really, really sad. But that's just my perspective as a Canadian.
This teeny little prick, but you can look away, okay?
So So apart from doing blood work, what we would typically do in a case where non-accidental injury is suspected is we would call Child Protective Services. We would do multiple x-rays. So first of all, a chest x-ray and what we call a full skeletal survey, where you do x-rays of all of the long bones to make sure that, humerus or femur fractures haven't been missed in the past. And the last thing that we would do is a genital exam to make sure that the patient hasn't been sexually abused as well.
He's obnoxious.
Well, what he is your competition. He's a gunner.
Yeah, right.
So a gunner is a term that we use in medical school where a medical student is very aggressive and quite obnoxious about trying to seek opportunities. And oftentimes they will have a bit of a cutthroat attitude with other medical students while trying to steal opportunities away from them. So this is what they're referring to as a gunner.
You don't think he's angling for an emergency residency spot here next year?
So this is actually quite accurate. When medical students are rotating through different emergency departments, usually they're trying to show face with a lot of the attendings and get a reference letter. And there is a lot of competition for these coveted emergency residency spots in highly desirable cities or hospitals where there are high volumes of really sick patients, whether it's a trauma center or a major referral center. So this is actually quite accurate. She should be worried that he's going to get the residency position over her.
Mr. Diaz.
Jesus.
He drunk?
No, ketones on his breath. He diabetic?
I don't know. Altered head trauma, possible
There's ketones on the breath, which usually has a fruity smell. So the things that we would think about are 3 different forms of ketosis. So one is diabetic ketoacidosis, one is alcoholic ketoacidosis, and the other one is starvation ketoacidosis.
Whoa, blood sugar is critical high, so over 500.
Ding, ding, ding.
So the patient's blood sugar is critically high, which means that the patient has diabetic ketoacidosis, which is a condition that happens when there's no insulin inside the body and the body can't use glucose as a substrate for energy. And so it starts breaking down fat as an energy substrate and starts producing ketones in the body. This can actually make your blood very acidotic and can make your electrolytes and kidneys go completely out of whack. It's a life-threatening condition, and we would treat this very aggressively with IV fluids and insulin and replace potassium levels if the potassium levels are normal or slightly low.
0.1 units per kilo?
No, not without knowing his potassium.
Yeah, so this is absolutely correct. You would definitely want to know the potassium level because once you start giving insulin, the potassium will shift from the bloodstream intracellularly, and this can actually cause your potassium levels to drop to life-threatening levels. So you would want to make sure that the potassium levels are normal or high before you start giving insulin.
Insulin causes an intracellular shift, and if the potassium is under 3.5, the drip would kill him.
That is very true.
We part of the standard order set, right? Dr. Mohan.
I love the competition and the sizing up of these two.
I can do it. 7.5 club.
Can I just say we evaluate our students not only on their fund of knowledge and on their procedural mastery, but also maybe more importantly on their skills as team players?
Absolutely. That's absolutely true. You have to be able to work with a medical student and a resident, and really the rotation that they're doing in the hospital is what we would consider a job interview. We would imagine working with this student for 4 or 5 years throughout a residency program. And if they seem like they're abrasive with other team members, a know-it-all, or just unpleasant to be around, we typically wouldn't offer them an interview for a job.
She can do it.
These are crazy Grandpa Jimmy's.
He's from my grandfather's brother's side. Grandpa Ricky is still a psycho. Clearly runs in the family.
So I think the one thing that's a little bit unrealistic about this is most of the wound care for a burn would be done by nurses, not often a doctor in the emergency room. The other thing is with fresh burns, we're typically not de-roofing and debriding all of these wounds. We would typically apply different ointments to the wound, kind of dress it up, and then send them to a burn clinic in about a week's time, or 5 to 7 days, where they would be reassessed. And at that time, if the blisters have actually popped, then they would start de-roofing the blisters. Because if you start to debride the wounds too early, that can expose yourself to a risk of infection.
This is Mr. Randall. He's been a wreck for the last 8 hours.
Should have gone down by now, right?
It happens. It's a good thing he came in, Mr. Randall. I'll take him right back. Do you mind finishing up with the Bickersons?
So he's coming in with what we call priapism, which is when you have either painful or painless erection. And this can be quite a time-sensitive and penis-threatening condition if you don't treat it right away.
Enter the dorsal side to hit the corpus cavernosum. I'll hold the glands. How deep?
2 centimeters.
Wow, I can't believe they're showing this. Crazy.
No, that's right.
This is actually very accurate.
You
We
guys
would
do
drain
this,
out the
like,
corpus
every day?
cavernosum by poking the sides of the penis and draining it out with an 18-gauge needle. And then afterwards, you disconnect the syringe and start injecting phenylephrine to constrict those blood vessels.
We're lucky.
The other thing that we would typically do is we would do a dorsal penile nerve block where we inject lidocaine or an anesthetic along the top aspect of the penis to make everything numb so that the patient isn't experiencing pain.
Harry Mitchell, eating breakfast at Pamela's, sudden onset respiratory distress, some stridor, decent pulse ox with trouble speaking.
And they tried the Heimlich?
3 times.
So stridor means that there's noisy breathing, particularly when you inhale. And the two things with this story that I would be concerned about are 1, a foreign body that's stuck in the airway, and 2, anaphylaxis with swelling of all the tissues in the upper airway. Apart from listening to his breathing, what I would be looking for is I would be taking his shirt off, looking for any kind of rash, and trying to get other stories to see if the patient has a history of anaphylaxis or allergies.
Draw up ketamine and rocuronium.
What about ketamine only?
No, we need full paralysis for a successful first pass intubation.
Might not need an intubation if it's just a foreign body.
We can't assume that.
So what they're debating right now is whether to give a sedative like ketamine in combination with a paralytic called rocuronium. Rocuronium usually lasts for 30 to 60 minutes in your system, and it takes away all of your muscle energy around your body, including your diaphragms. And if you give ketamine with rocuronium, you're committed to intubating the patient and putting them on a ventilator for at least 30 to 60 minutes. If you give ketamine only, the patient will continue breathing, and it will give you enough time to actually look down the airway to see if there's a foreign body or an object that you can remove. You can remove it, and then 15 minutes later, the patient will be waking up on their own and up and walking, and then they can be discharged from the hospital afterwards.
Could be subglottic stenosis, epiglottitis.
Hey, Dad, ketamine and rock.
Ketamine only, 80 milligrams.
So I 100% agree with Dr. Robbie. I personally would have only given ketamine only. And I think giving ketamine and rocuronium just seems like a very aggressive move in this situation.
In that case, I'll leave this in your capable hands.
Okay, let's lay it down and take a look.
Okay. Good view of the epiglottis.
So we use this tool all the time in the emergency department. This is what we call a video laryngoscope. And this would allow you to put a tube down into the patient's trachea to breathe for them. It would also help you identify different objects in the airway.
Mystery solved. This is what you get for eating broccoli for breakfast.
Get a good grip on it.
So she's using what we call McGill forceps, which is an angled clamp, and allows you to turn the airway to pull whatever object is down there
See why the
out.
Heimlich didn't work.
Rotate a little bit. Voila!
Broccoli.
That is why you give ketamine alone.
That is a
Because if
very
you give
satisfying
paralytic,
airway
you have
removal.
to intubate and ventilate for an hour.
The one thing that's unrealistic about this case is that if someone had a piece of broccoli or any other foreign body in their airway, typically they would be coughing and retching constantly throughout their encounter. They wouldn't be kind of like lying there just in the bed. I've seen a few patients with upper airway obstructions because of foreign bodies, and every one of their faces have been beet red, and they're just constantly trying to cough it out or retch it out.
We got combative college kid. Flipped down the library, tased in the neck by campus security. 5 Midazolam didn't touch him.
So this is something that I see all the time working in a downtown inner city hospital. It looks like he's coming with agitated delirium, and the paramedic has already given 5 of midazolam, which is a pretty high dose of a benzodiazepine. So if he hasn't responded to that and he's already pinned down and feeling like that, I would really be concerned that he has stimulants on board and would probably be giving higher doses of benzodiazepines. Sometimes we even give a pretty big dose of ketamine in the muscles to sedate a patient so that they're not fighting us while they're in the hospital.
Tell me some more about your ideas.
Maybe later.
Let me out! Let me out! Let me out! Let me out!
All right, that's it for episode 2 of The Pitt. Another great episode. There were a few very minor inaccuracies, but apart from that, it was actually a very fair representation of what we do in the ER every day. If you found this helpful, like and subscribe to the channel. And if you have any questions about anything that happened in the episode, drop it in the comments. I'll see you in the next one.